behalf of DCN. Thanks all for your precious time. Today I would like to highlight the next 5th of the March we are completing 7 years at the Zanish Cancer Hospital. So I would like to showcase some of my journey of compassionate patient care, personalized affordable cancer care with the focus on continuous learning. So as you know, I completed my MBBS from VS Hospital, MS also from VS Hospital, MCH from the one of the largest regional cancer center, that is Naranpura Cancer Hospital between 2011 to 14, and did completed my fellowship for advanced complex laparoscopic surgeries from the mentorship of Dr. at Galaxy Chemistry. So I have a total cumulative experience of over 14 years. So my journey started of private practice from the day one in 2011. 3 years. Next slide. So 3 years I was doing freelancing, was attached with multiple hospitals, and gradually in 2014 I had a vision of establishing my own cancer center. At that time, a sudden trend was there. Many senior surgeons were shifting, closing down their clinics and shifting to corporate hospitals. So it was a really challenging time. So I had to convince myself, but I was sure that I need to be an entrepreneur first, and then I can grow. So 2014, it was actually a reverse trend was going on. Many doctors were shifting their base to corporate hospitals, but at that time there was a huge need for a small, good cancer hospital, those who can provide personalized cancer care with affordable cancer care. So at that time, I had a vision of a good semi-modular OT with infrastructure. So you can see all these equipments. So even today, I can proudly say it is not available in some good multi-specialty hospitals. So that is all this semi-modular OT panel, double dome OT lights, mind ray workstation, multipara with CO2 monitoring, that is very essential for long surgeries and advanced laparoscopic surgeries. Of course, Bovidian cautery. Next. And then Carl Store's laparoscopic set, this double dome autoclave machine. So I can proudly say that this infection rate is less than 1%. So because of this double dome autoclave, so there are almost 0% infection rate is there across the all surgeries. So this was a huge investment on those days, but on the day one my vision was that I need to do almost all my surgeries one setup, then I can grow. So almost 1 CR was invested for OT and all equipments, and then we are giving services related to all surgical oncology right now. Also, we have added since last 3-4 years aggressively we are giving indoor chemotherapies also under expert care of medical oncology then, including target therapy, immunotherapy, and also we are focusing on post-treatment rehabilitation and preventive services also. So my journey started, many CMEs were done, many networkings were happening, and was doing freelancing surgeries, and then 2014 was the time when Zanish Cancer Hospital was started. So this is the audit report. You can see total approximately 250 chemotherapies we have given, total new OPDs around 2,200, total old OPDs around 6,000, total surgeries till date at Zanish we have done 860, and including my residency and freelancing, I can say I have done more than 5,000 cancer surgeries. From those 860, 40 were laparoscopic surgeries. You can see the high number, 205 is a complex microvascular reconstruction. Thanks to Dr. Harshvardhan, he is the integral part of my team. So we can proudly claim that apart from corporate setup, this is a really good number, and we have done excellent work and we are proud for that. So these are 205 microvascular surgeries, around 200 breast surgeries, head and neck around, including microvascular, 270 cases. On table mortality is 0 till today. And I had to shift around 8 patients to other hospitals for better ICU care from maybe on post of day 3-4. So that always we take a concern for some surgeries. We always know, but that is also you can see from so ICU care is a myth. What I believe, if clinician is present full time and with good post-operative care is available, so hardly less than 2% cases require routine ICU care. So that is there. Then these are some of photos. I started my surgeries as a freelancing surgeon, then gradually shifted my all base here. These are some of the cases, interesting cases you can see. Previous slide. Previous. So this is a BCC case reconstructed with a good nasolabial flap. This is a very challenging case of already operated case, commando surgery done, then had a second primary CL larynx, and then total laryngectomy was done in a totally scarred neck. So still patient is surviving after 3 years. So it's a really good memory. This is a 14 years old boy having sarcoma post chemotherapy. Then we had to remove tumor end block with the help of a segment of it. These are some of the photos of free fibula reconstruction. Donor side photo is there. Next. Many times during advanced uterine Vardhan surgery, incidentally traumatic injury happens. That also with the help of urologists and sometimes on myself, ureteric reimplantation or ureteric repair is successfully being done. This is a geriatric lady. Next. Previous. Geriatric lady having a forehead tumor, 90 years old. So then tumor excision was done end block, and then reconstruction was done with the help of local flap. Huge ovarian masses, huge colonic masses, all are resected end block. Very interesting, 12 years old unmarried girl having a cyst tumor. So end block dissection was done with the segment of small bowel. Next. So this is a reconstruction done by Dr. Harshvardhan. Lady very keen on a breast reconstruction as well as a bilateral symmetry. So after BCS, volume replacement was done with the help of LD flap. So you can see the defect. It's a huge defect. This is a post-op photo. This is a case of Whipple surgery. You can see the nicely done pancreatic with jejunostoma anastomose. This is a nightmare for surgeon. If it leaks, then there are high chances of mortality. But we have done 4 to 5 Whipples here, so no mortality, and just minor leak was there in 2 cases, and that were managed conservatively. And this was a really challenging case. I attempted with the help of laparoscopy. So that is not commonly done. People have started doing it. So with the help of laparoscopy, all mobilization was done, and then anastomosis was done in the open method. So patient could be discharged on the post-op day 8. Next. This is also interesting case which Mr. Neil was referring. So with the help of his SQLab 3D system, I did Wett's upper lobectomy for the carcinoma tumor of the lung. So because of his technology, huge vision, and this power stapler, really it's a miracle, because patient will have a pain-free post-operative period, and patient could be discharged on the post-op day 4th and 5th. So that was also one of the milestone case at this hospital. Many thyroid cases I am doing with the minimally invasive surgery with the help of small incision. So after sometimes there is barely visible scar is there. These are all head and neck reconstruction, scarless surgeries. So in DCRA when we were trained, at that time trend was that you put a big incision neck and you split a lip, and that is a comfort zone is there for surgeon, and we do a 3D wide excision. So since my second year in training, I started putting single incision in the neck only, so that is a minimal, barely visible scar is there under the collar line. And as far as possible, if tumor permits, then I don't do any lip splitting. So Harshvardhan can vouch for that, and people will have a no scar on face, and we can do a big resection also, and with help of microscopic reconstruction, and that is also giving us good results. Same patients are returning with the new patients because of these scarless surgeries, head and neck. Next. So these are all huge masses. This is a radial forearm flap surgery. These are all huge masses. It can vary from 10 to 20, 25, 30 centimeters. So it's all about anatomy. You need to respect the anatomy. You need to preserve the vital structures, and you need to remove all these structures and block. That is important. Next. Just all GI surgeries, anastomosis which are done nowadays, most of them with the help of staplers only. This extensive neck dissection with the help of reconstruction. You can see single scar on the neck, no scar on the face. This is Whipple surgery. This is a PMC flap. Next. This is a tongue, post-operative tongue appearance. Patient can easily speak also, swallow also, and not much morbidities. So this is a chemopod insertion for a long-term chemotherapy infusion. So that is also we are routinely doing. Thyroid surgeries, properly lymphadenectomy. So you can see all the vital structures clearly, all external iliac artery, vein, ureter, everything is seen clearly. So it's all about R0 resection. It's not about doing surgeries, it's doing surgeries with the oncological principles. These are esophagectomy, thoracoscopic. So a patient definitely can walk home after esophagectomy on the 6th or 7th day. So these were some of the photos. So next. So some of these are my memorable, I can say adrenaline driven challenging cases like laparoscopic stomach gist excision, laparoscopic assisted Whipple surgery, laparoscopic colon rectum cases, thoracoscopic esophagectomy, VETS assisted left upper lobectomy, laparoscopic Vardha and uterine surgeries. We have done quite a lot of 14 to 15 hours long surgery for microvascular reconstruction. Sometimes arterial anatomy, venous anatomy is very challenging, and so these kind of surgeries can last for 14 to 15 hours. So thanks to my work staff, we are able to handle all these cases very efficiently. So many re-exploration also were done in the initial learning period in the middle of the nights. So that what we can proudly say that flap failure rate was less than 2%. Out of 100, only 2% patient need to be replaced. All the re-exploration was done in the middle of the night. One really good case was there post esophageal patient suddenly developed tension pneumothorax. So as we all be aware, tension pneumothorax is a very rare condition. But if it develops, then clinical diagnosis must, if we don't intervene, patient can die within 3-4 minutes. So at that time, bedside ICD was inserted at the SpO2 of 20%, and patient was salvaged. Now patient is disease free post 5 years. So this is a really memorable case. Many life-saving bleeder controls have been done previously. Bleeder control, emergency tracheostomy. So these are all satisfying moments, and this gives us drives to perform better and better, and more continuous learning I always try to do. Next. So what started in 2018 as a small vision, now I can say it's considered a leading standalone small surgical hospital for a cancer care. But now my focus is for more minimally invasive laparoscopic surgeries, organ preservation surgeries, starting of robotic technology also in a short time, more integration of AI tools in my day-to-day practice to improve productivity, overcoming challenges of research and advancement in clinical trials in private practice. Gradually, I want to shift to mentorship role to give back to experience and training to budding oncologists. And I am happy to share that already I have started working with 3 surgical oncologists, and maybe in next March 2 more people are joining in our team. So as a team of dedicated oncologists, we want to focus on this post-treatment rehabilitation wellness programs. I want to expand my team with like-minded surgical oncologists and planning for a bigger setup also. And if possible, collaboration with a corporate hospital for a hybrid model of practice. That is my vision right now. I am adapting to more and more cashless mode of treatment right now. Already started process of entry level accreditation with the Hiralme, and I am looking for more collaboration with other oncologists to give best services to patients. Aggressively focusing on, I am also focusing on aggressive medical tourism patients to bridge the gap in cancer care worldwide, identifying areas of improvement and innovation. Already we have treated 5 international patients. So that is also giving us more boost. So you can see in this photo, when I started my journey, my son was only 1 year old. Now he is matured and is 8-year-old going into the school. So this both journey is going simultaneously. So I need to balance both the lives. So you can see how this growth happens. This smile tells you everything, how this journey is going on. Next. So main USP at the end of the presentation, I can say this high patient satisfaction is there with the burden of marketing driven consistent growth, with the full-time presence of clinicians and protocol-based treatment, and that is complemented by highly supervised nursing care, which gives patient flexible, cost-effective, and there are lots of flexible cost-effective finance options are there. So I can say any patient from any strata we can cater to this service, and with my expanded team, even we can cater to some poor patients also with the Ayushman Yojana also. Thank you. So for this reason, we need a lot of collaboration. I look forward to your support also in my future journey.
Yes, we have referred your patients to Vision Vibe, and they are doing really well. मतलब एक दिन में डिस्चार्ज, आज भर्ती हुए और एक दिन या 2 दिन में ऑपरेट हो गए, तीसरे दिन डिस्चार्ज. And there is no post of antibiotic needed, nothing, only 15 pillars they are doing that. तो तो क्लीन सर्जरी है और कॉस्ट वाइज दे आर आल्सो हैप्पी, उतना खर्चा भी नहीं।
It's all about it. Actually, the antibiotics are not needed. Only clean contaminated surgery is required. Otherwise, for clean surgery, it's not needed.